Today, we are really getting into some critical high-stakes pharmacology. We're looking at the drugs used to manage what is arguably the most powerful muscle in the human body, the uterus.
It's an incredible topic. And,
Mm.
we're looking at sources that really underscore how this isn't just about chemistry.
Right.
It's about timing. The myometrium, this huge wall of muscle, its responsiveness just changes so drastically depending on the hormonal climate and where you are in the pregnancy.
So our mission for this deep dive is to take this really complex pharmacological landscape and, break it down. We need to understand not just what these drugs are, but how they're manipulating this biological timetable that nature has so carefully calibrated over 9 months.
And it really boils down to two opposing forces, pharmacologically speaking.
Two sides of the same coin.
Exactly. On one side, you've got the uterine stimulants. We call them oxytocics. These are the drugs designed to increase uterine motility, especially as you get close to term.
And that's where we find the big names, like oxytocin, ergot alkaloids.
Prostaglandins, yep, the go signals.
And then on the other side, you have the complete opposite challenge, the uterine relaxants, or tocolytics.
These are the agents of delay. They're used to decrease uterine motility, to try and postpone labor, usually when the fetus is premature, and that's where, the risk-reward balance becomes incredibly sharp.
It's a fascinating area because, as the sources point out, even though the uterus has innervation, it's really the hormones and these drugs that call the shots.
Oh, absolutely. The nervous system plays a role, but it's the circulating hormones and the drugs that can have these profound, immediate effects.
Okay, so let's start with the big one, oxytocin. The word itself is so well known, but pharmacologically, it's just this tiny nonapeptide, 9 amino acids.
And the history behind it is, it's a fantastic story of early 20th century biochemistry. Oxytocin comes from the posterior pituitary gland, and it shares that space with another hormone, arginine vasopressin, or AVP.
Also known as ADH, the antidiuretic hormone.
Right. And clinicians were using crude extracts from the pituitary gland to speed up labor way back in 1909. But for decades, there was this huge debate.
The big question was, is it one molecule doing two jobs, stimulating the uterus and affecting the kidneys, or is it two different things?
Precisely. And this whole controversy, this mystery, it was finally put to rest in 1953.
By Vincent de Vignaux. And this was, a truly foundational moment for peptide chemistry, wasn't it?
It was a breakthrough.
Yeah.
He didn't just separate the two, he figured out their exact chemical structures, and then he synthesized them in the lab. It was a Nobel Prize-winning achievement.
And when you look at the chemistry, it's just wild how similar they are.
It's amazing. They're both 9 amino acids long, but they only differ at 2 spots, positions 3 and 8. And that tiny little difference creates 2 completely distinct life-sustaining hormones.
So where do they actually come from? They're released from the pituitary, but they're not made there.
No, they're synthesized way up in the hypothalamus in these nerve cell bodies, the supraoptic and paraventricular nuclei.
And from there, they travel down the axon.
Yep, they're transported down these long nerve axons, bound to these carrier proteins, and they're just stored in the nerve endings in the posterior pituitary, basically waiting for the signal to be released.
So what triggers that release? How does the body decide which one to send out?
It's all about function. Oxytocin release is triggered by things related to reproduction and bonding. So coitus, the process of birth itself, or the tactile stimulation of suckling.
And ADH?
ADH is all about stress signals related to water balance, things like dehydration, hemorrhage, or an infusion of hypertonic saline. The body is saying, we need to conserve water now.
But the key is that the ratio changes, right? It's not always an all-or-nothing release.
Exactly. The proportion of oxytocin to ADH that gets released varies dramatically, depending on what the initial stimulus was. It's an incredibly fine-tuned system.
Okay, so this tiny peptide is released. How does it translate that signal into the massive, coordinated effort of labor? Let's talk about the uterus itself and this sensitivity curve.
Right. Because the uterus isn't just a passive target. Its receptivity to oxytocin changes hugely over the course of the pregnancy.
In the beginning, it's not very sensitive at all.
Barely listens.
Yeah.
In a non-pregnant or early pregnant uterus, you'd need a ton of oxytocin to get even a small response. But then, throughout the 3rd trimester, that sensitivity just starts climbing.
And then right at the end, it spikes.
A massive spike right near term. It's like the organ has been primed and is just waiting for that final signal.
It's turning its volume dial all the way up.
You could say that. And that change is almost entirely driven by the hormonal background. Estrogens are the sensitizers. They literally increase the number and the affinity of oxytocin receptors on the muscle cells.
While progesterone is doing the opposite. It's the brake.
Progesterone keeps things quiet, decreases sensitivity, and maintains the uterus in a relaxed state for most of the pregnancy.
So estrogen is slowly cutting the brake line as you get closer to term. Let's get into the cellular mechanism, because this is where the precision is. It's independent of the nervous system.
Completely. It's pure chemistry. The action is mediated by these specific G protein-coupled receptors, or GPCRs, on the myometrial membrane.
And when oxytocin binds to one of those,
It kicks off a cascade. It activates a specific type of G protein, GQ, which in turn activates an enzyme called phospholipase C.
okay, phospholipase C, what does that do?
It chews up some of the phospholipids in the cell membrane and generates two really important second messengers, inositol triphosphate, or IPRs, and diacylglycerol, DJAG.
And IPRs, that's the key that unlocks the vault.
That's one. IP zips over to the sarcoplasmic reticulum, which is the cell's internal calcium storage tank, and triggers this massive rapid release of stored calcium.
But you said that's only half the story.
Right, because the binding also causes the muscle fiber to depolarize.
Right.
That opens up channels on the cell surface, voltage-gated calcium channels.
So you get a double whammy, the calcium flooding in from the outside and calcium rushing out from the inside stores.
Exactly. And that creates this big, sustained increase in free intracellular calcium. That's the signal that gets the actin and myosin filaments to slide and the muscle to contract. It's a powerful amplifying system.
And there's another layer of amplification, isn't there, involving prostaglandins.
Yes, the sources highlight this. Oxytocin binding also stimulates the endometrium to synthesize and release prostaglandins. And prostaglandins are themselves really potent uterine stimulants. So oxytocin is basically recruiting a backup chemical army to boost the whole response.
So when it's all working correctly, what does a proper oxytocin-driven contraction look like?
At low controlled doses, which is what you want for a safe induction, it increases both the force and the frequency of contractions.
Yeah.
But the crucial part is that you get full relaxation in between.
Which is vital for the baby.
Absolutely vital. That relaxation period allows blood flow to return to the placenta, reoxygenating the baby. It's only when you get into high-dose territory that the basal muscle tone starts to rise, and that's when things get dangerous.
And there's a specific pattern to the contraction physically.
Right. At term, the action is mostly in the fundus and the body, the top and middle of the uterus. The lower segment, down by the cervix, is often passively stretched or even relaxed. That's what allows the baby to descend.
Let's talk about its other jobs, because oxytocin isn't just about the uterus. The most famous one is in breastfeeding.
The milk ejection reflex, or the letdown, it doesn't make the move. That's prolactin's job.
Right. It delivers the milk.
It delivers it. It causes these smooth, muscle-like cells, the myoepithelium, which are wrapped around the milk-producing alveoli, to contract. That squeezes the milk out into the ducts so the infant can get it.
And physiologically, those cells are even more sensitive than the uterus.
Much more sensitive. The infant's suckling triggers a super-fast neural reflex that tells the brain to release a pulse of oxytocin.
What about outside of reproduction, the cardiovascular system, for example? You said high doses can have a pretty dramatic effect.
Yeah, at conventional doses, it doesn't really affect blood pressure, but at higher doses, it's a vasodilator. It causes a brief but pretty significant fall in blood pressure.
Which would lead to a reflex tachycardia, flushing.
Exactly. And this effect was actually so reliable it was used historically.
Ah, this is the chicken bioassay story.
This is it. Before they had precise chemical analysis, one way to standardize the potency of a pituitary extract was to measure the drop in blood pressure it caused in an anesthetized chicken.
That's incredible. It just shows you how far we've come in terms of precision.
It really does.
And we also need to talk about its effect on the kidneys, because clinically, this ADH-like action is a major risk.
A huge risk, because oxytocin looks so much like vasopressin, or ADH. At high concentrations, it can start activating ADH receptors in the kidney.
So it tells the body to hold on to water.
It does. It decreases free water clearance. Now, imagine a situation where you have a long, difficult induction. The patient is getting high doses of oxytocin, and they're also getting large volumes of IV fluids.
That sounds like a recipe for disaster.
It can be. The body retains all that water, which can lead to a condition called water intoxication. The sodium levels in the blood get diluted, which is called hyponatremia, and that can cause cerebral edema. Even worse, the fluid overload can back up into the lungs, causing pulmonary edema, which is a life-threatening emergency.
So to put it all together, what is oxytocin's official role in starting labor? Is it the sole initiator?
The consensus from the sources is no, it's not. It's not obligatory.
Meaning labor can start without it?
Right. Delivery still happens in humans or animals who've had their pituitary gland removed. It just tends to be a much longer, more difficult labor. So oxytocin's role is really as a facilitator. It comes in to strengthen and coordinate contractions that have already started, working alongside prostaglandins and other factors.
So let's move into that clinical practice. How do we use this powerful tool, and what are the risks we're balancing?
Well, the pharmacokinetics are really the key to both its usefulness and its difficulty.
Being a peptide, you can't take it orally. Your stomach would just digest it.
Right. So it's given either IM or, for controlling labor, by a slow, controlled IV infusion. There's a nasal spray, but that's really just for helping with milk ejection.
And its half-life is incredibly short.
Just 6 to 12 minutes. And it gets even shorter at term. Now, for most drugs, that would be a huge problem.
But for labor induction, that's actually its biggest asset.
It is the single most important safety feature. Because it's given by a slow, titrated IV drip, and its half-life is so short, you have exquisite control.
If the contractions get too strong or the baby shows any distress.
You just turn off the drip, and within minutes, the effect starts to fade. That controllability is why it's preferred over other stimulants like ergometrine.
And the pregnant body itself has a way of breaking it down.
Yes, the uterus and placenta produce an enzyme called oxytocinase, which specifically degrades oxytocin. It's part of the natural system that keeps things in check during pregnancy.
So, the advantages are clear. You can control it, it allows for normal relaxation between contractions, and it spares the lower uterine segment. Let's talk about the big, high-stakes uses. First up, induction of labor.
Induction is done for a lot of reasons. Maybe the pregnancy has gone post-term, or the mother has preeclampsia or diabetes, or there's some issue with the placenta where it's safer for the baby to be out than in.
But you can't just start an oxytocin drip on a whim. There's a strict safety checklist.
An absolutely vital checklist. Before you even think about induction, you have to confirm the baby is head down, that the lungs are mature, that there's no sign of fetal distress, and critically,
no cephalopelvic disproportion, meaning the baby's head can actually fit through the pelvis?
right, and no placenta previa, where the placenta is blocking the exit. Also, and this is a big one, no uterine scar from a previous C-section.
Because a scarred uterus is at a much higher risk of rupture.
A catastrophically high risk. The protocol itself is incredibly cautious. The oxytocin is heavily diluted, started at a tiny rate, and then slowly increased until you get a good physiological pattern of contractions. You're constantly monitoring the baby's heart rate and the strength of the contractions.
The second major use is for uterine inertia.
This is when labor has started on its own, but the contractions are just weak. They're not effective enough to make progress. So oxytocin is used to augment them, to strengthen them.
But all the same safety rules apply.
Every single one. This isn't a tool to just speed up a normal labor. It's for when the process is stalled, and it has to be done by very experienced people.
And the third, and maybe most dramatic use, is for postpartum hemorrhage, or BPH.
BPH is a major cause of maternal death. It often happens when the uterus fails to contract down after the placenta is delivered, a condition called uterine atony.
So here, the goal is completely different. You're not looking for rhythmic contractions anymore.
No, here you want brute force. You give oxytocin by IM injection or a rapid IV infusion to get a massive, sustained, tonic contracture of the entire uterine muscle.
And that contraction acts like a natural tourniquet.
Exactly. The muscle fibers of the uterus are arranged like a mesh, and the blood vessels run through them. When that mesh contracts with incredible force, it physically squeezes those vessels shut and stops the bleeding. It's life-saving.
And it's preferred over the ergot alkaloids in women with high blood pressure.
Yes, because it doesn't have the same systemic vasoconstrictive effects that the ergots do, which we'll get to.
Okay, so we've covered the uses. We have to now spend serious time on the warnings. The consequences of getting this wrong are catastrophic.
The line is incredibly fine. The most obvious danger is just overstimulation, contractions that are too strong, too frequent, or last too long.
Hypertonus.
Hypertonus or tachysystole. And the dangers of that are, first, soft tissue injury to both the mother and the fetus. You're basically using a battering ram against an incompletely opened door.
And the most devastating risk.
Uterine rupture. Especially if there's a scar or an unrecognized CPD. A rupture means immediate, massive hemorrhage and almost certain fetal death if not managed in seconds.
And we must come back to the risk of water intoxication.
It cannot be overstated. When you have a prolonged induction requiring high doses of oxytocin and large volumes of IV fluids, that ADH-like effect kicks in. The kidneys hold on to water.
Leading to that dangerous drop in blood sodium level.
Glutional hyponatremia.
Hmm.
And that causes water to move into cells, causing them to swell. In the brain, that's cerebral edema, confusion, seizures, coma. And in the lungs, the fluid overload leads directly to pulmonary edema. It's a critical and potentially fatal complication that requires meticulous monitoring of fluid in and fluid out.
Briefly, what about the analogs, like carbetocin? Are they designed to be safer?
Carbocin is an attempt at refinement. It's a long-acting oxytocin analog. Its main advantage is that a single dose after a C-section can provide that sustained contraction to prevent PPH for hours without needing a constant, monitored IV drip. It simplifies things.
Okay, let's transition to the other major class of stimulants, the ergot alkaloids, ergometrine and methylergometrine.
Right, and if oxytocin is the precision instrument, the ergots are the sledgehammer. And that's not a bad thing, you just have to know when to use the sledgehammer.
The key difference is the type of contraction they produce.
A completely different type. Oxytocin, as we said, gives you phasic contractions with relaxation in between. Ergot alkaloids produce a powerful, sustained, rigid contraction, a contracture.
And they don't spare the lower segment.
They hit the entire uterus top, middle, and bottom, including the cervix, which is why they are absolutely contraindicated before the baby and placenta are out. If you give it before delivery, you risk trapping the fetus and guaranteeing a uterine rupture.
Their mechanism is also totally different from oxytocin's.
Completely different pathway. Their effect comes from being a partial agonist at two different receptor types. Serotonin receptors, specifically 5-TXHT2, and also alpha-adrenergic receptors.
So that stimulation of multiple receptor types is what leads to that rigid tonic state.
It seems to be. Instead of the very specific controlled calcium signal you get from the oxytocin receptor, the alpha-adrenergic and serotonergic stimulation creates a more generalized, sustained depolarization and calcium influx that just locks the muscle down, overriding any natural rhythm.
And sensitivity, again, plays a huge role.
A huge role. The uterus becomes incredibly sensitive to them at term, and especially in the early period right after delivery. Methylergometrine is the more common one used now. It's a bit more potent on the uterus and has a slightly better side effect profile.
And they're more versatile to administer?
Much more. They're well absorbed orally, which is useful. And the onset is very fast, almost immediate with IV use. A single dose lasts for 3 to 4 hours, which is much, much longer than oxytocin.
So their clinical use is extremely narrow and focused.
Entirely focused on the period after delivery. Their one and only primary job is to control and prevent postpartum hemorrhage. They are the go-to drugs to slam the uterus shut and stop the bleeding.
And often used with oxytocin in a severe bleed.
Yes, it's a great combination. Oxytocin gives you that fast initial contraction, and the ergometrine makes sure the uterus stays clamped down for hours afterward.
Now, the adverse effects are significant, mainly because of that alpha-adrenergic activity.
Right. There are powerful vasoconstrictors systemically, so the most important side effect is a rise in blood pressure. Nausea and vomiting are also common.
Which leads to some very strict contraindications.
Absolutely forbidden in anyone with hypertension, any kind of vascular disease, or preeclampsia. The vasoconstriction could trigger a stroke or a heart attack. They're also avoided in sepsis, where they could worsen ischemia, and in patients with liver or kidney disease.
This really hammers home the difference. Oxytocin is for labor, ergometrine is for the aftermath.
They are completely different tools for different stages of the same job.
And the final group of stimulants we need to touch on are the prostaglandins.
Right. PGs like TXPGE2 and TXPGF2-alpha are incredibly potent uterine stimulants, especially late in pregnancy. But they have a huge dual action advantage.
They don't just cause contractions, they also ripen the cervix.
Exactly. And that is a massive benefit for induction, particularly if the cervix is still firm and closed. PGs get both parts of the process started, the softening and the contracting. This is why a prostaglandin gel or insert is often the very first step in an induction.
And newer analogs have made them even better.
Yes. Misoprostol, which is a TXPGE analog, is used everywhere now. It's cheap, you can take it orally, and it has fewer side effects. It's become a cornerstone for both labor induction and for medical termination of pregnancy.
Okay. We have spent all this time talking about how to start and strengthen contractions. We need to pivot now to the complete opposite challenge, how to stop them.
The world of tocolytics.
Yeah.
And this is an incredibly difficult and high-risk area of medicine.
The mission here is all about buying time. You're trying to delay premature labor, which is labor before 37 weeks.
And you're not trying to stop it indefinitely.
I
The
know.
goal is to buy a few hours, maybe 48 hours at most. And in that window, you have 3 critical goals.
Let the fetus mature a little bit more.
Give the mother a course of steroids to help mature the baby's lungs.
And if necessary, transfer the mother to a hospital with a high-level neonatal intensive care unit.
Exactly. Every hour you can buy makes a difference. But, and this is a huge but, the sources are very clear. Our success with tocolysis is limited.
We're not always successful, and the long-term benefit to the baby isn't always certain.
That's the honest truth. We don't have a magic bullet. We're trying to pause a process that has already started, often for reasons we don't fully understand, and the drugs we use have their own significant risks.
And they are absolutely not for everyone.
No, they are contraindicated if the membranes have ruptured, if there's bleeding from a placenta previa, if the mother has a severe infection or severe preeclampsia. At a certain point, the risks of keeping the baby in are greater than the risks of being born premature.
So what are our options? What are the main classes of drugs we use to try and hit the pause button?
We have a few different mechanisms we can target. First are the beta-adrenergic agonists like ritodrine, then calcium channel blockers like nifedipine. We also have oxytocin antagonists like atosiban, and then a few miscellaneous agents.
Let's start with that first class, the beta agonists. Ritodrine is the classic example, but it comes with a pretty tough risk profile.
It does. Ritodrine is a selective beta agonist. When it stimulates those receptors on the uterine muscle, it increases the level of an intracellular messenger called cyclic AMP, or CAMP.
And more CAMP means less contraction.
Essentially, yes. It inhibits the enzyme that's necessary for the muscle fibers to engage. So to get it to work, you start a slow IV infusion, and you gradually increase the rate until the contractions stop,
More.
where the mother's heart rate hits 120 beats per minute.
And that tells you right there that the drug selectivity is not perfect. You're hitting the heart, too.
You are. Beta-2 receptors are also found in the cardiovascular system. So the treatment window is very narrow, usually no more than 48 hours, because the maternal risks start to accumulate rapidly after that point.
And what are those risks? The complications can be quite serious.
They can. The cardiovascular side effects are the big ones. Hypotension, a very fast heart rate, arrhythmias, and most dangerously, pulmonary edema.
Fluid in the lungs again.
Yes. And then there are the metabolic issues. It can raise blood sugar, cause high insulin levels, and dangerously low potassium levels. The bottom line is that its use has been shown to increase overall maternal morbidity.
Which has led to it being discontinued in some places.
Right. It's been discontinued in the U.S. because of this unfavorable risk-benefit profile, but it's still available in the UK and India.
What about the baby? Are there risks to the fetus?
There are. The maternal hypotension can reduce blood flow to the placenta, which could cause hypoxia. And neonates can sometimes have issues like low blood sugar after birth, so it's contraindicated in mothers with diabetes or heart disease.
Given that profile, it's no wonder the field moved towards calcium channel blockers like nifedipine.
It was a logical next step. The rationale is so simple. No calcium influx, no contraction. Nifedipine is a powerful CCB that blocks the entry of calcium into the muscle cells.
How does it stack up against ritodrine?
In terms of efficacy, they're pretty comparable. It works in a similar percentage of cases. The huge advantage, though, is that nifedipine has significantly fewer maternal side effects. You don't see the same high rates of pulmonary edema or the metabolic problems.
But because it's a smooth muscle relaxant everywhere, you still have to worry about blood pressure.
That's the trade-off. Hypotension and tachycardia are still major side effects at the doses you need. So reduced placental perfusion is still a concern. But a key finding has been that fewer babies delivered after nifedipine treatment needed intensive care compared to those who got beta agonists.
Which brings us to what seems like the most targeted approach of all, the oxytocin antagonist, atosiban.
Atosiban is a really elegant piece of pharmacology. It's a peptide that's designed to look just enough like oxytocin to bind to the receptor, but not enough to activate it. It's a pure blocker.
So, in theory, it should have almost none of the systemic side effects.
And that's exactly what the trials show. It effectively suppresses contractions with significantly fewer cardiovascular and metabolic complications than the beta agonists. It's just a much cleaner mechanism.
But it's not available everywhere.
It's not. It's the preferred agent in Europe and the UK for inhibiting labor between 24 and 33 weeks. But it hasn't been approved in the US or India yet, which just highlights how complex global drug regulation can be.
Let's wrap up with the miscellaneous agents, starting with a really important one, magnesium thalate.
Magnesium is a fascinating drug. Its primary life-saving use in obstetrics is to prevent and treat seizures in women with preeclampsia and eclampsia.
But it also relaxes the uterus.
It does. It acts as a tocolytic because magnesium ions compete with calcium ions for entry into the muscle cell. It's basically a natural calcium channel blocker.
So if it works, why is its use just for delaying labor now discouraged?
This is a really critical update in modern practice. While it is absolutely essential for seizure prevention, its use as a primary tocolytic, when preeclampsia is not the issue, is now generally not recommended.
And why is that?
The evidence started to show that its use for tocolysis might actually increase the risk of perinatal mortality. There are concerns about it causing respiratory depression in the newborn and potential long-term issues with bone development if used for extended periods. The risks just started to outweigh the uncertain benefit of just delaying labor by a day or two.
So it's a side effect we accept when treating preeclampsia, but not a primary goal anymore.
Precisely.
And what about the most powerful relaxant, halothane?
Halothane is a general anesthetic, and it is an incredibly effective uterine relaxant. You don't use it to manage preterm labor, but you reserve it for specific short-term situations where you need the uterus to be completely flaccid-like, trying to manually turn a baby inside the uterus. It's a tool for acute emergency maneuvers.
Okay, so we have done a full tour of this pharmacology, from the precision of oxytocin to the brute force of the ergot alkaloids, and then into this really challenging balancing act of the tocolytics.
And we've seen all these different pathways. G-protein coupling, serotonin and alpha receptors, calcium channels, all funneling down to this one single goal of controlling this one incredibly powerful muscle.
What really comes through from the sources is that this is the definition of precision medicine. The line between a life-saving intervention, like using an ergot for PPH, and a catastrophic error, like a uterine rupture from too much oxytocin, it's a razor's edge.
There is absolutely no margin for error. Every single decision is a complex risk assessment, weighing the risks to the mother against the profound consequences of a premature birth.
Which leaves us with a final provocative thought. We've just spent a lot of time talking about how our current tocolytics, ritodrine, nifedipine, they're all fraught with risk. We're essentially using crisis management tools to stop a biological process that's already a runaway train.
Right. And the sources briefly mentioned that using high-dose progesterone in the second half of pregnancy has shown some success in preventing preterm labor in high-risk patients. It helps maintain that natural state of uterine rest.
So that raises a fundamental question, doesn't it? Instead of focusing all our energy on these high-risk, acute interventions to stop labor once it's started.
How might the entire field shift toward preventative, long-term hormonal strategies? Could the future be less about hitting the emergency brake and more about proactively maintaining that uterine quiescence throughout the later stages of pregnancy, maybe with something like long-acting progesterone? That feels like a paradigm shift from reactive crisis intervention to proactive, sustained prevention. And that could be the real future of tackling the preterm birth crisis.